Welcome to Health System CIO's interview with Martin Fisher, Chief Information Security Officer at Northside Hospital. I'm Anthony Guerra, founder and editor-in-chief. Martin, thanks for joining me.
Glad to be here today.
Very good. Martin, you want to start off? Tell me a little bit about your organization and your role.
Sure. Northside Hospital, we're in Atlanta. We're a 5-hospital system. We have about 300 outpatient departments, about 200 practices that roll up. Probably the thing we're best known for locally is about 35,000 babies are born in our women's center here in Atlanta every year. So women's services is a really big service line, oncology, cardiology. And I've been here about 8 years, building a security program from scratch over that time. Fantastic place to be.
All right, very good. So let's, I always like to find out how CISOs wound up where they are. So let's talk a little bit about your career journey. I saw that, I think you came into healthcare in 2010 from Delta Airlines. So
Yeah.
that's an interesting switch. I always like to find out sort of a couple of things. One is how people wind up in healthcare, and then how they specifically wind up on the security side of IT. So if you want to take
Sure.
me through your career a little bit.
I'll answer the second question first. So I ended up in security actually by accident. Prior to being in security, I worked a lot in release engineering. I owned these, I was managing and owning the software source code repository at the airline when my boss got moved over to be the CISO at the airline. And he needed someone to come in and help build the security operations side. So he asked me to come over, and Barry was fantastic. He's one of the best bosses I've ever had. I'm like, absolutely, I'm going to jump at the opportunity to learn a new thing. And, got into security there, and it was sort of like, duck water. I really enjoyed it. Spent time there, like a lot of things, your time at a company ends. So I moved over into healthcare. And a lot of people think commercial aviation and healthcare, they're so radically different. They're actually not. And here's why. And for those of you who do healthcare, you'll get this. Pilots and physicians are very similar personality types. Pilots, when they're flying that aircraft, they have a couple hundred people in a stainless steel tube miles above the earth, and they're responsible for the lives of everyone on that plane. Physicians, especially some of the surgery specialties, they have that person's life. Even the primary care docs, the health and welfare of that patient is in their hands. Nurses and flight attendants, very similar personalities. Everyone thinks normally the flight attendant is there to make sure that you have your Diet Coke and your peanuts and whatever in your blanket or whatever. And yeah, but the real reason they're there is if things go sideways, their job is to get you off the aircraft in less than 90 seconds. Nurses are not there to plump your pillow and make you, they're there if you code or what. So, and I think for me, I'd like to think I was pretty successful with the airline, understanding the pilot and the flight attendant mindset. It did not take long for me just to pivot it 30 degrees to realize that they're very similar, and that how you approach security in healthcare, I think the reason I was successful with the airline was I made sure that the pilots and the flight attendants understood I was on their side. They did not need to be on team security side. Team security needed to be on team flight operations. In healthcare, my doctors, my nurses, my everybody, they don't need to be on team security side. Team security needs to be on patient safety, patient care side. And as long as you're aligned that way, the amount of friction the security program generates just drops. And that's where you get the opportunity to have those really great conversations with your primary stakeholders on, we're all aligned. Can you help me do this security thing we need because patient safety, because patient care?
Very good. So that's a lot of great stuff in there. One is I was worried that you were going to be offending nurses with the comparison to flight attendants, but then you really made flight attendants, you flattered them, And then also you flattered the nurses, so it works
Because
out.
what they do is
Yeah,
so insanely important, and it's
yeah,
so easy, I think, as a patient sometimes, because you don't realize it until the bad thing happens, and all of a sudden there are three nurses, standing around you, taking care of you, and yeah, yeah, flight attendants and nurses are some of the most underappreciated people out there.
I think that's really, really good points. You mentioned the similarities between aviation and healthcare. I think you're on to a lot there
Yeah.
about the personalities with surgeons and pilots. They're also extremely highly regulated industries,
Yes.
which creates a specific environment for a CISO to operate as
Yeah.
opposed to retail. You're working for the Gap or something like that, right?
Well, I think you know the regulations at the time I was in the airline industry. So I was doing security, before, during, after 9/11, and that was really an inflection point across
Mm,
everything. Um, I think that they are regulated, and I think a lot of it is, for me, the way I think about regulation is that, yeah, I have to follow it, but I am more of a outcomes driven CISO. What is the regulation trying to get me to accomplish versus the prescriptive? That's one of the reasons I'm not a huge fan of PCI. Don't tell me what to do. Tell me what it is you're trying to accomplish. Um, that's why I think HIPAA is actually a pretty good regulatory framework. The security rule and the privacy rule describe the outcomes you have to achieve. Achieve those outcomes, you know, HHS doesn't care how,
hmm.
just get them done. So for me, it gives me the flexibility as a technology and a security leader to see what I've got in my toolbox, to see what works inside my environment, apply it, achieve the outcomes, and we're all good to go.
Right, right. And do you think the fact that healthcare, there's so much on the line, just like aviation, you don't get to make a mistake.
Right.
How does that change the environment for a CISO?
So it's interesting. One of the things that we do when we're interviewing, especially leaders that are going to come into the security organization that are not from healthcare, they may come from here in Atlanta, we have a lot of fintech, FinServe people. We have a lot of people who used to wear orange aprons, and they're great people. But to your point, they're not necessarily in overly regulated environments, the way we are in healthcare. And I'll generally ask the question at some point, what do you think is the most important thing? What do you think keeps this CISO up at night? What's my biggest concern? And generally speaking, those folks, pause for a moment and they think about it. They're like, well, if there was a huge breach of medical records, and their answer is not wrong, right? They just don't understand the context. But what I'll try to do in that moment is say, look, I've got tens of thousands of devices on my network. The majority are connected to a person. It could be an infusion pump. It could be a radiology device. It could be something in rad-onc where we're delivering radiation treatment. Um, if that device gets popped, it's connected to a person, we could hurt or kill a person.
Hmm.
That's what I worry about. Now, the evaluation part for me is you can look into that person and go, did they get that? And if you could watch them have that aha moment, that person could have a spot on. But there are some people who just no, 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 no. It's the data. It's the data. It's they're confidentiality, integrity, availability, and they look at it in that order. When from us, it's availability, integrity, confidentiality, and that inversion of the triad, the normal prioritization of the triad. Some people, when you explain to them why it has to be that way, they get it, and those are the people that we keep talking to. Some people just they can't get their brain around it, and we wish them well, and there are going to be other industries they can work in. Healthcare is probably not going to be one of them, but it's that, because if you think about it, you don't come to my hospital to sleep in my bed, eat my food, or wear my clothes, because they're all pretty suboptimal compared to what you could get at any hotel in town. You're here because you're sick,
Hmm.
or you need care, and the worst thing I can do is hurt you or hurt your loved one who's here. every nothing else really matters if you can't accomplish that. So everything we talk about here is patient safety. If you look at the mission statement of my group, number one, we ensure patient safety. We ensure quality of care. Then we protect data. in that order is how we do it. And again, that for me, when when I show other clinical leaders, here's our mission statement. Those who don't know me, they're kind of like, who've been around maybe other CISOs. They kind of, wait, what? You're speaking patient safety, patient quality language. Yes, because we both have the same patient. I just approach it differently. And from as a healthcare CISO, I have found that just living that, breathing that, again, reduces the friction. Because again, I'm showing the team security is on team patient care side.
It's so important to have that sort of North Star or true north or whatever the proper example is. And then
Absolutely.
so much, if you have that right, so much flows from that. So many things get worked out because of that. If you don't have that vision point right, or that end vision right, you're going to make a lot of mistakes. So
But you have to walk the talk, right?
yeah.
We've made decisions here that if I was to, like, pull some non-healthcare people and say, we chose to do this,
Hmm.
their eyes would get big and be like, oh my gosh, how could you possibly do that? Patient safety. We chose to accept a risk because the alternative was a patient safety risk. Okay, got it. And because I interact with directors and VPs across the organization, and with some of our senior clinical leaders, they see us walk the talk. And now what that does, it's not just, hey, the security team rolls over. There have been some really not difficult but intense conversations with some of our key clinical leaders, where I come to them like, I totally understand the patient safety stuff, but we really need to do, like, with Log4j, we took some outage to remediate that because of, oh my gosh, this could burn the world down. Because they know that I'm on team patient safety, and they know that I'm on team patient care, they're going to pause and listen, and we can have a conversation. And I have the credibility with the org to say, we need to do this. We really need to do this. And then I'm given the space to make it happen, because they know I would not bring it up if it truly wasn't the kind of issue that needed to be resolved.
And not all these decisions are clear, even when you have a true North Star, right? Because you
Right.
could be you could be trading one type of risk for another type of risk.
Mhm.
So, for example, one of the things we saw with COVID, with the ramp up to handle COVID, was a lot of CISOs green lighted apps and to get things on telehealth and different things
Yeah.
they didn't have the time to do the normal process that they
Mhm.
would have, and they
Yep.
accepted that. They said, we understand, we're going to give this a pass and we're going to go with it now because we need to take care of patients, and we know we're taking on probably more risk than we would have otherwise. And then there was the process of having to go back
Mhm.
after things calmed down and, okay, what the heck did we buy now, or what did we turn on now, what can we do to remediate some risk? Did you go through the same type of thing?
Absolutely, of course I did.
Yeah.
Right. And any health system CISO who says otherwise either is unaware or lying.
Hmm.
Right. Being a CISO, a healthcare CISO during a pandemic, has been one of the most interesting experiences of my life, because we took everything we had done to date, every single plan we had about how we onboard new technology and how we assess risk, all of those plans evaporated because of the reality of what was happening in our ICUs and in our EDs, and us putting medical triage tents up in our parking decks, right? I mean, we've not seen that. So for us, it was, one, being invited into the conversation with clinical leadership around, we need to do a thing. We need to go telehealth fast and hard. Um, and we were brought in to help guide that conversation. Here are the three people that we're looking at, and security was asked, who's the least bad, right?
Yeah.
Who's bringing the least risk?
Right.
And we would do a very fast assessment and say, based on what we know, this is how I would rank rate them. They're like, well, we want number 3. Okay, right. I'm going to get out of the way. Now, again, to your point, there's I'm going to have to circle back and fix this. And what can
Right.
I do right now to help mitigate that risk. And us talking with our counterparts on the privacy side, talking with our counterparts on the compliance side, talking to outside counsel who could really understand what OCR was saying, and where OCR was drawing the lines. All of that fed into that conversation, and then collectively security made a recommendation to leadership, and we were part of that decision making process. That's all that I can really ask for. But yeah, I mean, everyone had to do it, because again, patient safety, quality of care, we had, otherwise our doctors wouldn't be seeing anyone, and that's not how things should work in a pandemic.
Let's talk about those risk decisions that I've heard over and over again, that CISOs want to explain the risk, understand what the business is looking for, explain the risk, explain the options, and then the business ultimately is going to make the decision. So,
Yep.
to use your example of giving them a 1 through 3 ranking in
Mhm.
terms of risk, and I'm not sure how you articulate the associated risk other than saying these are 1 through 5. If there's more information you give in terms of some further detail for them to understand the risk. So you say,
Yeah.
here's 1 through 5.
Uh-huh.
They say, we want 3. You say, okay, you understand. I've explained to you why it's 3, why it's not 1, why it's not 5. What makes that 3? That's the one you want because of the functionality, understanding the risk level. Okay, Mr. Business Owner or Mrs. Business Owner. Is that how it works?
No.
Okay, tell me.
So again, this is a very specific Northside leadership culture thing. It may be similar elsewhere, and it may be very different elsewhere. Using telehealth, right? Here are our
Hmm.
3 options. Actually, there were more options. There were a couple that we said, please don't do this. So here, please don't do that one.
Wait. So let's start at the beginning. Who's saying here are the options? They're saying here's what we want, or you're
Right there,
saying?
we would work with our friends over on the IT application side.
Hmm.
We're in, there's clinical folks. It's essentially it's a team of people who like quickly research the options, and the options bubble up, and we help rank rate. But at the
Hmm.
end of the day, it boiled down to, here are the 3 that we feel we can adequately handle. There were a couple more that we looked at that, just from my perspective, there was a lot of things wrong with both of them, not just from a security perspective, but we didn't believe they could handle the capacity, so on and so forth. So they just fell off for technical and practical reasons as well. But out of the 3, it was my response was, here are the 3 in rank rated order. I can secure any of them, and a choice was made. I don't then continue explaining unless I'm asked a question. Now, there's certain leaders here who are very detail oriented. They will take, if they want, they'll take a rabbit hole and follow it down to the molten core of the earth. And I need to be prepared for that, right?
Right.
I'll show our assessment. There are some who are like, is it red, yellow, green? Or can you, do you, Martin, understanding you're on team patient safety, do you feel we can appropriately secure this? And we have that conversation. And then my job is to sit back and let the business decide, of those 3, which is going to be the best, quality of care. Which one can the physicians use most easily? Which one integrates with our EMR and with our rev cycle, and all those other things that, from a security perspective, well, as a healthcare technologist, I'm interested in, but they're outside my lane. So here are your choices. Pick one. I'll secure whichever you choose. That's how the conversation works.
Have you ever had now or in the past somebody push back on the, to use your example, the ones that were dropped off the list? Did you ever have somebody say, hey, that's the one I wanted, so can you make that work?
No, that never happens.
So
Of course it
how
does,
does
right?
that dynamic go?
It really depends. I mean, a
Okay.
lot of it is, and again, a lot of it depends on, here at Northside. Again, I think I'm very fortunate in that I can have candid conversations about why, right? And again, because we're all on team patient safety, we're all team on quality of care, I can explain why this is endangering safety, or why this is usually endangering quality of care. And not just this pinpoint solution is going to have impacts over here that you didn't think about. And again, because we have a lot of good conversation, there's a lot of trust. Um, the conversations work out. Now, sometimes people do get emotionally attached to product X. Sometimes
Mm-hmm.
it'll be, some new physician leader has come into the organization. I've always used product Z.
Mm-hmm.
Fantastic doctor. We don't use that, but I want to use that. Okay. In order to do that, I've got to build mitigating and compensating controls and essentially create a little product Z island out here.
Mm-hmm.
This is what it's going to cost. If you'll give me your cost center number, I can start building it with your budget. And then the conversation morphs, right? Um, are there times when we deploy things I'd rather not? Sure, happens all the time. But again, my job is not to tell people no.
Mm-hmm.
My job is to sometimes say not like that.
Mm-hmm. Right.
Um, and
Or
because
not like that unless you want to pay for it.
well, I mean, yeah, exactly. But even then, it's like I just want to deploy, product Z, right? And it's going to be, well, no, we've got to do these other things as well. So I'm not a clinician. I don't run rev cycle. I don't run all the, my job is I stay in my lane. And because I stay in my lane and I respect, not only stay in my lane, I respect other people's lanes, they end up respecting mine. And again, I think it's part of a healthy culture to where there can be constructive tension, right? There's always tensions in an organization to where, my director for emergency services is laser focused on when an ambulance shows up with a trauma patient, how fast can we do things?
Mm-hmm.
I'm totally on board with what Chris wants to do. Then what I've got to do is wrap security around it fairly effectively and not in as little as possible get in his way. Now, my emergency services director respects my lane as well, right? He realizes that I'm here to help him and I'm here to help him help our patients. So it's this great tension where we can, this is probably one of the very first things I did was, we walked through one of our emergency departments together and we're able to, in about 10 minutes, resolve 3 problems to where he was happy, I was happy, and all the tension left the room. And that's winning.
That is today's environment more and more because of the high level, and this is me, and I'll get your reaction. That's today's environment because of the high level breaches we've seen where hospitals have been taken offline, so to
Oh,
speak, or
yeah.
back onto paper for a month or two, and you've got stated losses of over $100 million. We've seen that in California. That creates a different security environment for someone like you trying to enforce policies. That makes the people that you have to have these compromises with much more amenable to understanding your point of view. They've seen it in the news, they get it, they understand there's a patient safety factor now. We've seen some lawsuits, wrongful death, that kind of a thing. It wasn't like that 10 years ago, correct?
Right. Yeah, absolutely. It was totally different. We
So
were
these,
seen as an
yeah,
impediment.
right, right. So how would you describe that change and morphing as it's taken place over time?
So one thing I think that if I always try to look for the positive in anything, I think with this era of ransomware, some media outlets better than others have done a good job of explaining the impact of a ransomware event. And when you get to see what happens to cautionary tale 1, cautionary tale 2, where people are down for days, weeks, months, or simply go out of business, or you start seeing wrongful death lawsuits. Again, team patient safety, team patient care starts paying attention, and then nothing helps a CISO than having an outside third party validate what you've been saying for a long, long time. Sometimes we use a big 4 consulting firm to do it, but if it's CNN or the Wall Street Journal
Mm-hmm.
going, hey, this is a real thing, watch what happened at this hospital system, or that clinic, or whatever it is. Stuff got real. The hypotheticals that as a CISO we had been talking about for a long time, where it could happen, is now happening. And our clinicians have colleagues who are being impacted by it, and so it's become very real. And I think in talking with some hospital CISOs, there's that phrase in security, never let an
Right.
incident go unused. Some people are using it to sow further fear, uncertainty, and doubt, right? And talk about the ransomware boogeyman. That's probably effective over the short term. I think long term, if you've been engaging your clinical leaders, and you simply say, look, here, this is happening. Like I said, 2 years ago, can we do these things? There's going to be a lot less resistance from the clinical side. Actually, for me, there's been almost no resistance from the clinical side. Budgets are opening up, right? Again, not because necessarily CFOs want to, it's not about lawsuit avoidance. It's, again, CFOs are on, a good CFO is on team patient safety, and they're on team quality of care. And they're realizing, hey, this investment we need to make in security, will help. And oh, by the way, the fact that, no one's getting cyber insurance anymore, hey, we just freed up $100 million that we can, do a more direct mitigation. So I think nothing brings a team together like a real adversary. Right?
Yes. Yes,
and
that's a very
so
good
right
point.
now in hospital land, we have a real adversary. And so we have a chance now to look at each other, either across a table or over a Zoom, and look at each other and go, how are we going to fix this? How are we going to fight this? How are we going to protect our patients? And it's in a kind of almost morbid way, it's made us a stronger team. So again, I'm trying to find any good I can in the era of ransomware. So there's that.
And do you leverage that some of that material in maybe presentations you make to boards and senior leadership to explain what's going on out there? And you don't want to use the boogeyman, like you said, but
No, but
you're
here's
just
the thing.
educating.
But here's the thing, they've already been educated. They know. Let's be honest. Every board member reads Becker's. They read the Wall Street Journal. They read all this stuff, right? They know, right? And if I was to come in and start educating them on ransomware, one, it's going to come across as being very pedantic. Two, it's going to come across as almost insulting, right? So if I'm going to talk to a leader, it's like, their question is generally, okay, ransomware, what are we doing?
Right.
Right. I'm not going to brief. I'm not going to educate. They know. And
Right.
at that point, it's like, because of this aspect, we're doing this. Because of this aspect, we're doing this. And it works. Are we doing everything I wish we could? No, because we don't have an infinite amount of money.
Right.
But I'm proud of the response Northside's made. I'm talking with a lot of peers. I'm proud of what a lot of hospitals are doing with what they have. And so again, trying to find whatever piece of good we can.
Very good. All right. I want to ask you sort of an open-ended question, see where you
Sure.
go. From a big picture point of view, what are either the top one or two things you're working on, or if you don't want to talk specifics about that, what are some of the most important trends or the most important trend you're seeing, either from a technology or process point of view on the security side that sort of has caught your eye, but maybe not everyone else's?
Oh, wow. So for me, I think a basic truth that I think some people are missing is that for a long time, we've counted on doing, inspecting the traffic on our network, because that is the surest telltale of where badness is going to be. TLS 1.3 is going to take that away from us. It's going to be very difficult for us to inspect east-west traffic because everything's being encrypted, as it should be. So we are losing visibility on the network. So that needs to move to the endpoint. That's harder, right? it's easier to aggregate things on the network and inspect it versus having to collect from tens of thousands of endpoints. And I think us trying to stay ahead of some of these older technologies getting deprecated to maintain the visibility we need across our environments is going to be key, because the amount of reaction time we get to badness is shrinking. I mean, it doesn't, when the attacker gains persistence and they decide to pull the trigger on badness, it used to be you had tens of minutes, an hour or two to realize what was going on and do something about it and still be pretty effective in your IR. Now you've got minutes, maybe seconds before real badness starts. So the only way you can do that is with visibility, understanding what's happening on your network. And it's IT 101. It's asset governance, it's data governance, it's basic blocking and tackling, but at scale and with a quality level that is hard. And I think that, to me, it's re-engineering and going back to basics is where I think for a lot of us, the next 5 years, that's what we're doing.
Does that require AI and ML in order to respond in seconds to breaches, or is that something different? And
I think, I kind of, AI ML is sort of, I call it RSA speak. It's great marketing. I think automation, I think it's part of it, but I think there's automation, there's the ability to stop doing security silos, to where, my NDR product does a great job here, and my EDR product does a great job here. By the way, my web proxy does a great job here. That's great. But you're watching the world through 3 different straws. You have to be able to see holistically across it. That's where I think the challenges are going to be. That was always the promise of SIM, right? Holistic knowledge across your entire environment. And then, wow, that's expensive. So, Anton Chewbacca was talking, on a thing the other day. It was like, that's an 8-digit bill if you want to throw that level of visibility into the cloud. He's probably right. But that's where we need to be. We need to be able to look holistically at our environment, figure out what normal is, and then focus on the not normal. And that's hard. And I think some people are better positioned to do it than others. I think folks, it's going to be a challenge. And that's where I think over the next 5 years, if you look at what the track was in financial services, look at what, the financial services ISAC has led. That's kind of where I think healthcare goes, just like any other critical infrastructure.
well, that's great. I'm telling you, I would go on with you for another half hour. We didn't get into sort of the whole cyber insurance thing. We'll have to do that another time, because I would like to keep these tight. But let me give you an opportunity for a final thought, final piece of advice for your CISO colleagues at health systems, something that you just want them to think about, or a nugget that you've learned based on all your experience. This is sort of one thing that has kept you in good shape.
So let's talk about CISO burnout. It is really easy for us to try to take on the world. As CISOs, generally, we are the security SME. We are the face of security in our environments, and a lot of us are very driven. But especially, healthcare CISO during a pandemic, we're burned out. And I think my only nugget is take care of yourself and take care of your people. Because if you flame out, if you, we've had, I've had peers who've, had to, go to inpatient behavioral health because they've just collapsed. If that happens, you're not doing yourself or your organization any benefits. Take care of yourself, take care of your people, because this is that class. It's not a sprint, it's a marathon. And right now it's not even a marathon. It is an eternal journey. So pace yourself. Take care of you, take care of your family, let your folks take care of themselves, let them take care of their families. Because if you're not around to fight the battle, you're not around to fight the battle.
And if I can use an airline analogy from your previous life, you got to put your mask on before you put your neighbors on, right?
Very much so. Yeah, exactly.
Or you can't help anybody. Martin, thanks so much for joining me today. Tremendous interview. I really appreciate it.
Glad to be here.